Good afternoon. Should I start? We are talking about the role of afferent pathway in blepharospasm and blepharospasm with dry eye. I have no financial interest and photos and videos used with consent. So blepharospasm as such is the involuntary contraction of the protractors of the eyelids. Conventionally, it's divided into two types: the benign essential blepharospasm, which has a central mechanism, and the reflex blepharospasm, secondary to dry eye or ocular surface issues. And the way to differentiate the two is often quoted as, if you put a drop of topical anesthetic in the eye, if the spasm improves, it's a secondary blepharospasm. However, studies also show that there are certain external stimuli which are known to trigger spasm in BEB, such as flickering lights, going outdoors, and so on. And there has been one study which rather counterintuitively shows decreased corneal sensitivity in BEB. On the other hand, we have a set of patients who have definitely clinically proven dry eye, including staining, Schirmer's, slit lamp examination, and they complain about not being able to keep their eyes open even with the maximum medical treatment. So now we have a dilemma, two sets of patients. These patients, we are afraid that if we are going to put botulinum toxin chemodenervation around these eyes, they'll probably end up with further dry eye and further lag ophthalmos, which will make things worse. So the question is, does the afferent corneal pathway have a role to play in blepharospasm, as well as blepharospasm in dry eye? So this is a prospective observational study, January 2020 to June 2021. Consecutive patients presenting with blepharospasm were assessed at oculoplasty and the cornea services at Narayana Nethralaya, and the control group was the consecutive patients of dry eye seen by the cornea services. The dry eye was treated with optimum management, and if persistent blepharospasm was there, they were referred back to the oculoplasty service. Esthesiometry was done for blepharospasm patients. Confocal microscopy was done to study the subbasal nerve plexus. Schirmer's test and ocular surface discomfort index was checked in all patients. A single evaluator looked at the blepharospasm, graded it by Yankovic grading, and injected incobotulinum toxin type A in a pattern that is determined by the inspection of the most forcefully contracting muscles. And the patient was reviewed at 3 weeks and to confirm that that was the correct pattern and dose, and followed up when the spasm recurred. And post-injection tear substitutes were continued. So as an example, this is a picture of a normal nerve plexus, where you see these three pictures are all from dry eye patients where the long nerve fibers are fewer, they're broken up into short bits, there are lots of dendritic cells, and the ends of the nerve fibers are swollen, causing microneuroma. Microneuroma is a formation that is known to be significant in neuropathic corneal pain. So ultimately, we had 86 eyes of 43 patients in 3 groups, with essential blepharospasm group A, group B combined dry eye and blepharospasm, group 3 dry eye with no blepharospasm. Group A and B, the two types of blepharospasm, had similar mean scoring, similar optimum dose of chemodenervation, and similar mean number of months of duration. There was distorted subbasal neural plexus seen in 27% of group A and B. Corneal sensitivity in both group A and B was decreased to 35 millimeters, where the Indian normative data talks about 54 to 58 millimeters. Microneuromas were more in group A compared to group B. Microneuromas were more in the blepharospasm group compared to the pure dry eye group. Ocular surface disorder index discomfort index was less in group A, but combined A and B were again less than group C. So afferent pathway abnormality was associated with BEB and dry eye associated blepharospasm. Now, this is an association. We cannot say that the afferent pathway caused the blepharospasm or whether the frequent forceful blinking of the eyelids caused a damage to the corneal epithelium. So blepharospasm with dry eye, however, is distinct from isolated dry eye, and it is also distinct from BEB. So it is okay to put the chemodenervation for blepharospasm associated dry eye, but tear substitutes have to be used in all essential blepharospasm, and probably in future one can look at the pain pathways also for the control of the blepharospasm. Thank you.